Hi, I'm Clare Thornton. I'm a consultant rheumatologist at University College Hospital, and I'm going to briefly, in the next 15 minutes, give you a quick overview of steroid-induced osteoporosis and how to assess and manage it. Contents of my talk are going to be a brief talk about what steroids do to bone, and then I'm going to go through the guidelines produced by the National Osteoporosis Guideline Group in the UK around 4 years ago and the treatment options that they suggest. So to briefly go back to preclinical medical school, glucocorticoid steroids mimic the actions of the naturally occurring steroid hormone cortisol that in all of us is produced by the adrenal cortex. It has profound effects on all organs, diffusing straight across the cell membrane, binding to its intracellular receptor and altering DNA transcription. It was recognised in the 1950s that exogenous steroids have profound anti-inflammatory actions, and even now they're the mainstay of treatment for many chronic autoimmune inflammatory and allergic conditions. So managing their side effects is going to be an important thing to do for, I think, many decades to come. In terms of their epidemiology, physiological steroid production is around 5 to 7.5 milligrams daily of prednisolone, approximately, and it's estimated that around 1 to 2% of the population in the UK does take long-term oral steroids. It's the commonest of the iatrogenic pharmacological causes of osteoporosis. There's a few other drugs listed here, and we need to bear in mind that there are a number of different preparations in which patients may be taking steroids. Oral preparations are those that we're most concerned about here, but long-term high-dose inhaled or nasal steroids, topical steroids can also have a role when they're taken over long periods of time. So we know that steroids can cause bone loss and increased fractures, and that's been very well established now for 30 or so years, that osteoporosis is really one of the most significant downsides to using steroids. These are some of the big meta-analyses listed here that have demonstrated this even at really relatively low doses. So 2002, Van Steyr et al. Showed that what we consider physiological doses can reduce bone mineral density and increase fracture risk. Even patients with Addison's disease having physiological replacement risk of bone loss, and high-dose inhaled steroids given for COPD and asthma have also been shown to cause bone loss, although not fragility fractures themselves. The effects of steroids on bones are as followed. The most significant loss of bone density occurs in the first 3 months of use, where there's a period of increased bone resorption. That's then followed by a long-term loss of bone synthesis, resulting in progressive bone fragility and increased fracture risk. The most characteristic complication are vertebral fractures, and we know that the effects of steroids are dose dependent, so those patients on really very high doses are at increased risk compared to those on the very lowest doses. We know that the effect on bones is actually partially independent of the effect on bone mineral density, but also fortunately that the effect diminishes as the steroid dose is withdrawn. Okay, so in this part of the talk I'm going to look at what the National Osteoporosis Guideline Group's latest guidance on osteoporosis in the UK says about how we can best structure our approach to patients on steroids to protect them from bone loss and fragility fractures. And then I think it's important to note at the outset that risk assessment for patients on steroids and management of osteoporosis is inadequate at present in the UK. It's under-recognised as an important consideration when using steroids for patients under the care of many specialties. I do have to acknowledge, though, that it's a really very difficult thing to do, even as a rheumatologist who spends a lot of her time looking after patients with osteoporosis. Inserting a discussion about osteoporotic complications of steroids into complicated consultations about the primary illness can be a hard thing to achieve, but we'll have to all try, I think, and do a little bit better at it. So the most important consideration is to start osteoporosis treatment at the outset of steroid therapy in the following groups. So those with a prior fragility fracture, all women over 70, and anyone who's over 50 who's on prednisolone for more than 7.5 milligrams a day for more than 3 months. In these patients, we should be starting osteoporosis treatment and then assessing bone density and looking at their fracture risk afterwards. In other groups of patients, it's considered okay to assess their fracture risk and measure bone density at the outset, and then look at osteoporosis treatment second. This is what the FRAX calculation looks like for anybody who hasn't done it or hasn't seen it in a prior presentation in this afternoon. So it's a series of clinical risks accompanied by age, sex, weight and height, and femoral neck bone density, and they're amalgamated to give your 10-year probability of major osteoporotic fracture and hip fracture separately. And then in the UK, you can click through where it says View NOG Guidance, and that will give you a chart that shows you whether your patient is falling into the category for treatment, for intensive treatment, or for adopting lifestyle measures only. And there's a few additional considerations to bear in mind when using FRAX. And I should also point out that there are other fracture risk assessment tools out there, Q-Fracture, for example, that could equally well be used when assessing patients on steroids. So within FRAX, it's assuming that the average prednisolone dose for the patient concerned is moderate at 2.5 to 7.5 milligrams daily. If your patient's on higher doses of steroids, then the fracture probabilities need to be revised upwards by around 15% for the major osteoporotic fracture risk and about 20% for hip fracture risk. Secondly, FRAX is likely to underestimate the risk of vertebral fractures in particular, since we know that steroids do disproportionately affect the lumbar spine. And finally, FRAX generally underestimates fracture risk in very frail patients with other risk factors for fracture, such as an elevated risk of falls. So when starting to look at how we can help patients on long-term steroids manage their fracture risk, before looking in particular at osteoporosis treatments, there are some general principles that we can all, as physicians managing patients on steroids, can try to follow. First, we can try to keep the steroid dose as low as possible and the courses of treatment as short as possible, using steroid-sparing drugs whenever we possibly can. Second, we can try to aim for topical treatments where they're an option, rather than offering parenteral oral courses of prednisolone, as it's well established that the systemic absorption and therefore the effects on bone of topical inhaled and intranasal steroids are much less than with their oral equivalents. Thirdly, we can advise patients about weight-bearing exercise. This has the advantage of protecting their muscle mass from the effects of steroids, in addition to protecting against bone loss. And fourthly, we can advise patients to avoid smoking and to keep their alcohol intake within safe limits. Finally, for particularly those frail elderly patients, we can try to make sure they're engaged in some efforts at falls prevention. For example, is their vision okay? And other. And lastly, particularly in younger patients, it's important to recognise and treat hypogonadism. So, for example, in women with serious illness, often they develop amenorrhea. If it's thought necessary, HRT or testosterone in men should be considered and offered. The next of the general lifestyle considerations is calcium and vitamin D replacement. So in all patients at risk of osteoporosis, and particularly all patients on steroids, it's important that they look at their dietary calcium intake and ensure that it's adequate, and that measures are taken to avoid vitamin D deficiency. I suggest to my patients that they use the International Osteoporosis Foundation Dietary Calcium Calculator. This allows patients to estimate through their weekly intake of various foodstuffs their weekly likely calcium intake, and if it's inadequate, then combined calcium and vitamin D supplements can be prescribed. Otherwise, vitamin D of around 800 to 1,000 units daily would be recommended. There is, from 25 years ago now, a Cochrane review looking at calcium and vitamin D supplementation in patients on steroids, and demonstrated that these measures alone improve bone mineral density by 2.5%. They weren't sufficient, however, to reduce fracture risk. So finally, treatment. And the osteoporosis medications with the soundest evidence base for use in steroid-induced osteoporosis are oral alendronate and risedronate, intravenous zoledronate, and then the parathyroid hormone analogue teriparatide for those patients who are at extremely high fracture risk. Around 10 years ago now, another Cochrane review was published looking at a meta-analysis of 27 bisphosphonate studies for glucocorticoid-induced osteoporosis, totaling just over 3,000 patients. They did demonstrate a significant improvement in bone density at both lumbar spine and neck of femur, and a reduction in vertebral fracture risk of around 40%, although not a significant risk reduction in non-vertebral fracture risk. Teriparatide is an option for those patients who are at very high risk, and the superiority of teriparatide over alendronate for steroid-induced osteoporosis was demonstrated in this study, again from a long time ago now, 15 years, Sarg et al., which enrolled 430 patients over a wide variety of ages and randomized them to receive either teriparatide as a daily injection or alendronate as an oral tablet for a period of 36 months. And as you can see here, there was a substantial improvement in lumbar spine and hip bone density with teriparatide. Both were significantly improved over time, but there was a quite substantially greater magnitude of improvement with teriparatide. Secondly, the table here shows you the reductions in fractures. So certainly the vertebral fractures were significantly reduced in teriparatide patients over those with alendronate. They weren't able to show an improvement in non-vertebral fracture rates, however. There's some additional considerations for patients who start osteoporosis treatment while on steroids. Firstly, if the FRAX assessment turns out to be below the threshold in those patients who are elderly and whom treatment has been started up front, it's fine generally to consider stopping treatment when the steroids themselves stop. However, if patients are likely to continue taking steroids long term, it's important that the bone protection continues long term too in the vast majority of patients. Although also important to bear in mind that decision making here needs to be shared between the patient and the clinician, and each patient's individual circumstances need to be evaluated and considered. Thirdly, in patients who are on lower dose steroids and in whom the FRAX risk assessment comes out below the threshold for treatment, it's important to consider reassessing after 12 to 18 months if you haven't started osteoporosis treatment in them, so that those patients where the risk rises abruptly can be found and offered treatment. Finally, it is important to consider osteoporosis treatment in younger patients, particularly if they're on long-term high-dose steroids or they've suffered previous fragility fractures. So to summarise, glucocorticoid steroids are the commonest iatrogenic cause of osteoporosis. Even comparatively low doses of steroids can cause bone loss and increased fracture risk. And really the most important treatment consideration is to think about it, risk assess and start treatment at the outset in older patients and in those with prior fragility fractures. Many thanks. Bye-bye.